Okay, having observed the patient, we can then get into the articular tests, the active, passive and resisted tests for the lumbar spine itself. And as much as possible, without having a fetish about this, we need to localize this to the lumbopelvic area and try not to involve the thoracic spine in these movements, as much as you can anyway. So, if we turn you around again, Beverly, sorry. Looking at flexion, for example, if I just put my hand on the sacrum and I have Beverly bend forwards for me as far as you can, and when she gets down as far as she'll go, I'll just stabilise the sacrum there and come up on the thoracolumbar area and just apply a little bit of overpressure there. And with extension, we'll bend her backwards through this range, being sure to support her at the back here. It'll give a full range of movement so that I can see what's happening, and then I overpress and let her back off again. So again, I've done active and passive testing. Lateral flexion, bends to the right for me. Stabilise the pelvis again, and just overpress there, and bend this way, and again overpress here. For rotation, we need to do this in sitting, and it's not absolutely a necessary part of the lumbar examination because the amount of rotation in the lumbar spine is really quite small. Consequently, it's really an optional part of the examination, and it will show up later on when we do stress testing in the lumbar spine. But if we're going to do this, we'll just have the patient sit on the bed for me, Beverly, would you? Just come down this way a little bit for me. That's lovely. And we'll get the patient to rotate to the right, and again overpress and rotate to the left and overpress. These two tests will give us a good indication of a number of things. The active movements will tell us something about the patient's willingness to move and therefore their perception of the acuteness of the problem. We can also see the range of movement. And having seen the range of movement, we can try and determine whether it's a capsular or a non-capsular pattern of restriction. If it's capsular and it's affecting both sides of the spine, we're going to find that extension, both side flexions and both rotations are really quite limited, while flexion is the least limited of the movements. This would suggest an arthritis in the spine, either traumatic or systemic. If it's non-capsular, it could be an articular problem, such as a joint subluxation or hypomobility, or it could be a disc lesion that's blocking the joint range. From the passive movements, we'll get an idea of the resistance being offered to that movement. So we're really interested in the end feel, whether it's a normal end feel or whether it's abnormal. Is it spasm? Is it capsular? Is it a springy end feel that you'd expect with a disc protrusion? If it's spasm, we may be looking again at arthritis, or it may be a larger disc prolapse or even a herniation. Does it reproduce pain? Both this and the active movement. And if so, where does the pain spread? If we're getting pain on the active and or the passive movements and it's a radicular type of pain, then we're looking at a neurological tissue being involved. If it's a somatic pain, then it's non-neurological. Where does the pain come on in relation to where the tissue resistance comes on? This will give you an indication of how acute the problem is. Obviously, pain that comes on before you actually hit tissue resistance as the end fill is really very, very acute. Pain that comes on only after you've stretched the tissues passively is obviously a lot less acute. So, from the active and the passive ranges, we can get an idea of what the resistance to the movement is and the acuteness of the problem, and also the pattern of restriction. From the passive overpressure, providing that there was no increase in pain, we could go straight to the resisted test in that stretched position. If there is pain when you do the overpressure or the active movement, then you need to bring the patient out of that position and retest the resisted movement in the neutral position. This is because if you apply a resisted test in a painful position, you may actually do quite a lot of damage, and you may take a disc prolapse and turn it into an extrusion, or even a protrusion and turn it into a prolapse with enough overpressure resistance. So remember, these tests are only done in the extreme of range when there's no pain being reproduced by the passive test.